Welcome to our monthly webinar series hosted by the Office of Integrated Healthcare Research and Policy and the Department of Family Medicine at the University of Colorado School of Medicine. Before we get started, let me tell you a bit about our sponsor and partners. This webinar series is sponsored by the California Mental Health Services Authority Integrated Behavioral Health Project. CalMESA is an organization of county governments working to improve mental health outcomes for individuals, families, and communities. Prevention and early intervention programs implemented by CalMESA are funded by counties through voter-approved Proposition 63, the Mental Health Services Act. The Agency for Healthcare Research and Quality, Academy for Integrating Behavioral Health and Primary Care, functions as a coordinating center and national resource for people committed to delivering comprehensive integrated healthcare. The Academy focuses on integrating behavioral healthcare and primary care practices and promotes a collaborative environment that fosters dialogue among leaders and other stakeholders in integrating behavioral health and primary care. The Collaborative Family Healthcare Association is a nonprofit, member-driven collaborative organization in existence since 1995. CFHA promotes a comprehensive and cost-effective model of healthcare delivery that integrates mind and body, individuals and families, patients, providers, and communities. Advancing Care Together, a project at the University of Colorado Denver Department of Family Medicine, is a 4-year program aimed to discover practical models to integrate mental health, substance use, and primary care services. The program is funded by the Colorado Health Foundation and funds 11 demonstration projects that have been organized as a set of diverse comparative case studies and will be linked to support cross-project learnings. Before introducing our presenter for today, I'm going to go over just a couple of quick housekeeping items for GoToWebinar. You can view the webinar through the GoToWebinar viewer, which should be on the left-hand side of your screen. And you can choose to listen to the audio through either the telephone or by selecting your computer's microphone and speaker. If you select the telephone radio button, the number to call in will appear at the bottom of the GoTo control panel. All participants are muted, and at the end we will have time for question and answer. And you can submit your questions through the chat feature in the GoToWebinar control panel, or if you would like, you can raise your hand and interact with our presenter directly. As a reminder, our webinar is being recorded and will be available to be viewed at a later date, and this is the YouTube channel. Additionally, our presenter has shared her slides, and so everyone should have received the slides prior to this webinar through email. If you didn't, I'm happy to resend and just send me a chat with your email address, or you can email me directly. So today we are pleased to bring you Dr. Sarah Morsbach Honaker. She is a licensed clinical psychologist with a board certification in behavioral sleep medicine and an assistant professor of clinical pediatrics at Indiana University in the Pediatric Pulmonology, Allergy, and Sleep Medicine program, where she conducts pediatric behavioral sleep medicine clinics. Her research area includes sleep intervention in children with disruptive behavior disorder, secondhand smoke exposure and sleep, and sleep in primary care settings. Thanks so much for joining us today, and I'm going to pass you control.
Okay, great. Thank you for having me, and thanks to all of you for attending the webinar and for your interest in this topic. Pediatric sleep is really an emerging field, and I think there's growing recognition of how important good sleep is in a lot of domains in child and family functioning. So objectives today are to describe current practices in addressing pediatric sleep in primary care. Most of the literature that's out there pertains to the practice of pediatricians. Unfortunately, there's not a lot out there yet on the practice of behavioral health providers addressing sleep in primary care or other primary care providers such as family medicine. And I do plan to cover both behavioral sleep disorders and concerns such as insomnia, and also what are sometimes referred to as primary or medical sleep diagnoses, so obstructive sleep apnea and narcolepsy. And a second objective is to give you information about a behavioral sleep toolkit for primary care, and in particular, some ideas about anticipatory guidance, screening, and interventions to address pediatric sleep. No conflicts of interest. Okay. So even though most sleep providers practice in sleep centers, the majority of youth with sleep difficulties are not seen at a sleep center and will likely never be seen at a sleep center. Pediatricians do report encountering behavioral sleep difficulties quite frequently in pediatric primary care. And this is data from a survey of Kentucky pediatricians. And you can see that more than half report that they're encountering sleep at least weekly, and about a quarter encounter that, or report that they encounter a behavioral sleep difficulty daily. So like with many other areas, primary care really is a crucial setting in which to address sleep. Yet at the same time, there's evidence to suggest that sleep disorders are under-identified in primary care. So this was a study that was done in the CHOP system, and the researchers examined many well-child check records and found that only about 3%, or between 3 and 4% of those in the study received any type of ICD diagnosis for sleep from their primary care providers. And the most frequent diagnoses were enuresis and sleep disorder NOS. In a subsample of the original sample, the authors examined 750 charts of those who had been diagnosed with a sleep problem, a sleep disorder, or who did not have a diagnosis. And they found that of those who were diagnosed with a sleep problem, only 5.2% had any type of a recommendation associated with that diagnosis. And the most frequent recommendations were some type of behavioral intervention, a referral, or to continue to monitor. And this is a table from that same study. And you can see in this column the general prevalence rates for the disorder. And in this column, you see the prevalence rates that were found in the current study. So for example, for nocturnal enuresis, there's a prevalence rate of about 15 to 20% of 5-year-olds, 1 to 2% of those older than 15. But in the sample, only 1.2% of the population received an enuresis diagnosis. If you look down at insomnia, so the prevalence rate 5 to 35%, and only 0.05 of 1% actually received an insomnia diagnosis. However, when you look at some other non-sleep disorders, you see that the prevalence rates do seem to match the rates that were identified in this study. So 13.5% prevalence rate for asthma, and in this study, 14.5% had an asthma diagnosis. So this is another study examining sleep screening in primary care. And they asked pediatricians how often they screened for the following items during well-child checks at least 3/4 of the time. And in general, a lot of pediatricians reported that they are screening across a number of areas most of the time. So 72% reported that they usually screen for routine sleep problems in children and bedwetting, typical sleep schedule. About just over half report that they usually ask about snoring. In adolescents, they report screening for routine sleep problems fairly frequently, and then more than half report that they usually screen for adolescent typical bedtime and wake time. And amongst those who did not report screening, the #1 reason that they did not screen was their belief that the parent will raise any type of sleep problem. Yet, in a different study, so this was a phone survey from the National Sleep Foundation Sleep in America poll, they found that only about half of parents are reporting that their child's pediatrician ever asks about their child's sleep habits. So there's a little bit of a disconnect there. This is a study that looks specifically at screening for obstructive sleep apnea. So this was in New York. So in a large urban sample, only a quarter of the children were screened for snoring. And perhaps more alarmingly, of those who did snore, or sorry, of those who were screened, about a third snored, which is fairly consistent with prevalence rates. But of those who snored, fewer than half received any type of further follow-up. So taken together, these studies suggest fairly low levels of screening and intervention. So let's take a look at some of the reasons why this may be the case. So some of the challenges to addressing sleep in primary care. So provider training, knowledge, and comfort. This lack of training was the most frequently identified barrier by providers. And then caregiver level factors. So what do caregivers know about sleep, and how often do they perceive sleep as problematic? What guidance is available about what to address when, how often to screen, what type of guidance to give at various ages? And there's really not a lot out there. And then, of course, as with any area, the structure of the primary care setting has offers some barriers as well. So high volume, short appointment times, a lot of areas to address. So I'm not going to talk as much about the structure of the primary care setting today, but certainly want to acknowledge that that's a factor. Okay, so the provider training variables. So for physicians, sleep education in medical schools internationally, the mean is 146 minutes, also less than 3 hours in the US, and majority adult focused. And in fact, the mean coverage for pediatric sleep is about 17 minutes. If we look at pediatric residency programs, again, we're looking at pretty low numbers, so 4.4 hours, 2.7 in the US, and about a quarter of residency programs report that they're not offering any type of sleep education. And in a survey of US pediatricians, only 18% reported that they had received formal training in sleep disorders. We look at other types of providers. So most nurse practitioners report that they have not received formal training in sleep in pediatric sleep or continuing education. And when we look at clinical psychologists, this was a survey of 212 clinical psychology training directors, and they found that very few graduate and internship programs offered didactic sleep courses, and fewer than a third offered any type of practica experience treating sleep disorders. So really across the board, providers are not receiving a lot of formal training. And if we look at provider knowledge, this was a test of knowledge of obstructive sleep apnea, and only about 2/3 of the items were answered correctly. Another knowledge test that looked at a variety of items across pediatric sleep, not just sleep apnea. The mean score was 3.32 on an 8-item quiz, and this was a true-false quiz, and so really you would expect a score of 4 just by chance, so this is not a good score. In terms of pediatricians' comfort addressing pediatric behavioral sleep concerns, you can see that really a lot of providers report that they are at least somewhat comfortable. So about 2/3 are reporting that they're at least somewhat comfortable diagnosing behavioral sleep problems, and more than half are reporting that they're at least somewhat comfortable treating behavioral concerns. So this begs the question as to why providers are so comfortable despite the fact that they have not had a lot of formal training. So are they doing independent study? Is there informal training? Many of them no doubt are parents. And then I think the second question is, to what extent does this high level of comfort actually reflect best practices and the science that's available about what works? And I think there's probably a lot of variability. And you can see here that the comfort levels definitely vary by types of sleep disorders. So 1 indicates very uncomfortable, 5 is very comfortable, and you can see that pediatricians report feeling pretty comfortable addressing poor sleep hygiene, sleep apnea, insomnia is somewhere in the middle, and much lower comfort levels assessing and addressing restless leg syndrome, delayed sleep-phase syndrome, narcolepsy, so definitely some variability. So let's transition to looking at some of the caregiver factors that offer challenges. So this is a study looking at caregiver knowledge of sleep, a survey of parents of young children. Again, these are true-false questions, and so you would expect a score of 5 just by chance, and the mean score was 4.39. They did not find any ethnic differences in sleep knowledge. They did find that better sleep knowledge was associated with more positive sleep behaviors and longer sleep duration. And this does indirectly support the idea that anticipatory guidance about sleep may have a positive impact. And 8% of parents reported that their child did not sleep enough, and yet about 3/4 of parents underestimated the amount that their child needed to sleep. And this is, again, I'm not going to go through all of them, but I do want to draw your attention to a few. So about half of parents are reporting their perception that snoring indicates that a child is sleeping well. And as we know, snoring is actually a symptom of obstructive sleep apnea and a warning sign for potential sleep apnea. So definitely not a sign of good sleep. Only 7% of parents correctly reported that this item is false. So the average preschooler actually needs between 11 and 13 hours of sleep for 24 hours. So definitely some gaps in knowledge. In terms of caregiver perception of sleep as problematic, so this is a study in Adelaide, Australia, and London and colleagues found that about 1/4 of the children that they surveyed had a sleep screener score that was in the clinical range, so clearly indicating problematic sleep. However, of those who had problematic sleep, only 4% of parents raised the issue with their general practitioner that day, and fewer than 15% had discussed sleep in the last month. So even when sleep is problematic according to a validated scale, few parents raised this concern with their pediatrician. Similarly, in another study in the Ohio area, in a community sample, when asked a global question, does your child have a sleep problem, 4% of parents responded yes, yet 1/3 of them had screener scores that suggested a sleep problem. And this was a study of almost 30,000 by Mindell and colleagues, and they surveyed caregivers of young children from predominantly Asian countries and found that they were more likely to report a sleep problem, so slightly more than half, compared to children from predominantly Caucasian countries, so the US, England, Australia, where about 1/4 of parents are reporting sleep problems. And the best predictor of which parents reported a sleep problem was the number of night wakings that the child has. So if the child is waking up a lot, the parent is more likely to report a sleep problem. There are some probable ethnic differences in caregiver perception of problematic sleep. So this was a large sample of over 3,000 US preschoolers, and Caucasian and Latina mothers were more likely to say their child had a problem falling asleep compared to African American mothers. And Caucasian mothers were significantly more likely to report that their child seemed overtired compared to Latina and African American parents. So let's take a look at some of the guidance that's out there on how to address, what to address and when. So this is an AAP report from 2012. The original report, I believe, was in 2002, so this is an update. And they reported that, or they recommended that clinicians should inquire whether or not the child snores. So in other words, they are recommending that all children should be screened for snoring. This is another American Academy of Pediatrics set of recommendations, and there's really a long history of good, strong recommendations around sleep safety in the first year of life, so a lot of recommendations in this guideline. And then the American Academy of Sleep Medicine has some practice parameters for behavioral treatment of bedtime problems and night waking, so insomnia symptoms in infants and young children. So they recommend behavioral intervention, and note also that parent education and prevention is effective. And then there's some additional guidelines from the AAP and the AASM for specific populations or conditions, so ADHD, autism spectrum, Down syndrome, obesity. So for example, all obese children who snore should be sent for a sleep study as one of the guidelines. So there are some guidelines, but not many and not really global, addressing a number of areas. And if we look at Bright Futures, which makes recommendations for pediatrics for screening and anticipatory guidance, anticipatory guidance is heavily focused on, anticipatory guidance about sleep is heavily focused in infancy in that first year of life. So you can see in this column, you can see the newborn visit, the 1 week visit, 1 month, etc. There's really a lot of attention paid to sleep, and in particular sleep safety. So back to sleep. And then also some recommendations around putting an infant to sleep drowsy but awake. So giving the child an opportunity to learn to self-soothe. And then at 15 months, we see recommendations around a bedtime routine, how parents should respond to night wakings, about a bottle in the crib. And then really there's nothing for several years. At age 4, there's some guidance around a bedtime ritual, and then no television in the bedroom, and the same at 5, 6, 7, and 8, which certainly has implications for sleep, but it's not really a sleep-specific guideline. And then really nothing in adolescence. In the 15 to 17-year-old age range, sleep is mentioned, but only as a possible symptom of depression if sleep changes over time. So I'm going to talk about a model of behavioral sleep screening and intervention that we used at the University of Louisville to try to address some of these problems in identifying sleep. So we had a sleep behavioral health consultant in primary care, so a psychologist with behavioral sleep training, and then a trainee as well. We essentially conducted sleep screenings, offered anticipatory guidance, offered tailored recommendations that were specific to that child based on what the parent was telling us, referrals and follow-ups and consultations. And we really found that families responded positively to the process. And so we had a 0% refusal rate. And in general, families seemed either positive and interested, or at the very least politely neutral. And this is just a sample of what one of the screeners looked like. So this was in our 0 to 2 age group. So we would ask whether the child's sleep was a problem, and then we conducted a validated sleep screening measure. This one is the brief infant scale for children. And then we would give age-appropriate anticipatory guidance. So we would just check off the items that we covered depending on time and the age. We would give handouts based on problems, and then one on normal sleep for the age group, and then follow-up, impression, and recommendations. And then this went in the medical chart. So the aims of the study, we wanted to describe the sleep of children living in an urban setting. We wanted to try and see how we best go about identifying sleep problems, and then also to examine physician perception of the service. So this is our sample. We have data from 83 of the screeners that we did, patients seen over about 2 years. Really a nice variety of, or a nice distribution of age groups. It was about 2/3 African American, about 1/4 Caucasian, half male, half well-child checks, and then a predominantly Medicaid population. So this is an urban clinic, a lot of psychosocial stressors and challenges in this population. So let's look at some of what we found about their sleep. So in this column, you see the National Sleep Foundation recommended range by age, and this is number of hours per 24-hour period, so this would include naps. This is the estimate of the U.S. mean for hours of sleep from the National Sleep Foundation Sleep in America poll. And you can see that these are close to but under the recommended range, and particularly in adolescents, we get much lower than the recommended range. And this was the mean total sleep time from our sample, and it generally tends to be slightly lower than the national sample data, probably because it was a tough population, like I said, that had a lot of challenges. Our adolescents had a little bit more sleep on mean, partly because we were asking about weekday sleep, and some of the screeners were done over the summer, so I think that inflated our estimate. What I think is particularly telling is the percentage of those we surveyed whose total sleep time fell below the recommendations. So insufficient sleep really was prevalent in this population, and I think in general, insufficient sleep is highly prevalent in the U.S. In terms of sleep habits, so a study by Mindell and colleagues identified two factors, infants through 10-year-olds, two factors that really predicted more sleep problems. One was having a bedtime after 9 p.m., and the second was parental presence at sleep onset. So kids who had a parent with them when they fell asleep were more likely to have poor sleep, and in particular, most likely night wakings. In our sample, more than 2/3 had their parents present at sleep onset, and 3/4 had a bedtime after 9 p.m. So clearly there was room for guidance around developing some positive sleep habits. In terms of whether asking a parent about their concerns identifies problematic sleep, in general, 20 to 40% reported that their child did have a sleep difficulty, or that they did have a concern about their child's sleep. Interestingly, none of the parents of newborns reported a concern, perhaps in part because there's an expectation that newborns are challenging when it comes to sleep. Of those who did report that their child had a concern, only 28% had any sort of documentation of problematic sleep in the medical chart in the past year. So these concerns are not necessarily making it to the pediatricians and into the record. Perhaps more disturbingly, of those who reported, no, my child does not have a sleep complaint, 1/4 snored, more than 1/4 took more than 30 minutes to fall asleep, which suggests possible insomnia, 1/4 had a clinically significant subscale score on the screener, suggesting a sleep disorder, and more than 1/3 are sleeping more than an hour less than recommended. More than half met at least one of these 4 criteria. So even parents who are not identifying sleep as problematic could clearly benefit from some more targeted guidance and screening and assessment. And so physicians' perceptions of the service were overall really quite positive. So on a scale from 1 to 5, with 5 denoting strong agreement with the statement, they felt that it was beneficial to providers and patients, to trainees, that the physicians themselves had improved knowledge of behavioral and medical sleep conditions. There were increased sleep center referrals, and in general, they felt that it was not disruptive to patient flow. In terms of the most helpful aspects, the sleep screening process was identified as the most helpful. So in sum, sleep disorders, problems, and poor sleep habits are quite prevalent. Providers are not receiving formal training, and guidance, identification, and diagnosis are insufficient in primary care. And parents of children with problematic sleep are often not raising sleep as a concern, particularly in a disadvantaged population. So in case you're feeling a little bit down or discouraged about this, there are some areas that are more encouraging. Families really do seem interested and willing to talk about sleep. Treatment approaches for behavioral sleep problems are highly effective, and we will look at some of that data in a moment. And if you can help families improve their sleep, it can dramatically impact many areas of child and family functioning: child health, child learning, marital satisfaction in parents. So really a lot of room for making a positive impact. And then a lot of behavioral sleep approaches are brief and well suited for primary care. So I am in the process of developing this behavioral sleep toolkit for pediatric primary care. There's a provider knowledge module, and then some information about what types of anticipatory guidance and when, about screening and assessment, intervention strategies, how to follow up, when to refer. And I'm going to talk a little bit more, or give you some parts of the toolkit for 3 of these areas: so guidance, screening and assessment, and intervention. So as we noted, there was not a lot of guidance from Bright Futures, but there is some guidance from the, written by sleep professionals that I think can really help parents. So this was adapted from Mindell and Owens, A Clinical Guide to Pediatric Sleep, which is actually a great resource for physicians, psychologists, for providers in general who are interested in addressing sleep in primary care, because it really has some of the most up-to-date evidence. And I'm going to highlight a couple of these areas that I think could be really helpful in terms of offering anticipatory guidance. So in that first year, putting the infant down drowsy but awake. So even parents who do not necessarily want to commit to doing a full-on sleep training approach with a sort of a cry-it-out type approach, if they get the infant as tired as possible, so rock them, get them very sleepy, and then try to put them down awake rather than rocking them to sleep or feeding them to sleep, a lot of infants will self-soothe on their own, which really prevents the need to do sort of a sleep training process later on. So again, giving the infant the opportunity to learn to fall asleep independently. In the 1 to 4-year-old range, really talking about an appropriate bedtime. In general, we talked about before 9 o'clock, and in this 1 to 4 age range, an appropriate bedtime is probably closer to 8 o'clock, although there, of course, is some variability. In the 5 to 11-year-old range, thinking about daytime sleepiness as a red flag. So for children who have given up their naps, being tired after school, being extremely tired in the morning, suggests that either they are not sleeping enough or that there may be a problem with their sleep quality. So for example, they may be snoring and they would need to have a sleep study to rule out sleep apnea. Also in this age group, the importance of an appropriate bedtime. So again, before 9 o'clock, and really prepubescent children, a bedtime that best matches their sort of natural circadian timing system is going to be earlier than a lot of parents think. In your adolescence, talking about what's normal and what's recommended for a sleep duration, the vast majority of parents of adolescents think that the adolescent sleep need is the same as the adult, so around 7.5 to 8 hours, whereas really the recommendation for adolescents is 9 to 9.5 hours of sleep, so they definitely do need more than adults. Also discouraging the weekend-weekday discrepancy in adolescence, but really across development. So having a bedtime and wake time on the weekends that is not more than an hour later than during the week. And then finally, in talking to adolescent parents about the role of insufficient sleep on all aspects of daytime functioning. And there's some really strong evidence that looks at risk-taking behaviors as well as mood. So really stressing to parents the importance of sleep in some of these sort of moods and behaviors that we think of as traditionally adolescent, but maybe as much attributable to insufficient sleep, which is really widespread. So anticipatory guidance and education has been evaluated extensively in infants and toddlers and consistently found to be very effective. How well the guidance works in later years is still under investigation. So for example, in a 5 to 11-year-old population, if you tell parents before 9 o'clock is an appropriate bedtime for your child. Do they actually do that, and how well does it work? And that we don't know as well, but we do know that the guidance works for the very young kids. So screening and assessment, I would recommend using a chart like this or similar really for any type of complaint that you're addressing, not just sleep complaints, but any type of behavioral health complaint that you're addressing, because sleep or insufficient sleep can cause so many symptoms that look like other disorders, and because it's so important to overall health and functioning. So what I'll typically do, and this is when I don't have a sleep log, and most of the time when you're going into a room in primary care, you don't, the family doesn't show up with a completed sleep log. So I'm asking, what is your typical schedule on the weekend? What time does your child go to bed? What time do they fall asleep? So how long does it take them to fall asleep? How many night wakings do they have? And what's the total time awake during the night wakings? And usually we don't worry too much about how much they're waking up, but the total time awake in the middle of the night should be less than 30 minutes. What time are they waking up? Are they napping? And then what is their total sleep time? And then you want to ask the same questions about the weekends, because really you can, just from the quick questions and the numbers that you have in this chart, you can see a lot about what might be going on with this adolescent. Tip, I haven't looked at this empirically, but based on my clinical experience, I would not bother asking how many hours a night do you sleep or how many hours a night does your child sleep, because oftentimes the number that you get is not going to match up with their actual total sleep time when we look at it objectively, or even when you ask them to complete a chart like this, the number you're going to get is different from what you would get if you just asked point blank, how much do they sleep? The BEARS, so the acronym is BEARS. This is a nice sort of rubric that you can use to ask questions if there's a sleep complaint. So asking about the bedtime, so what's the routines, is there resistance, are there fears? Excessive daytime sleepiness, so what's happening during the day? Are they hyperactive? Are they irritable? Is it really hard to wake them up in the morning? Usually if it's very hard to wake a child in the morning, that suggests that they're not getting sufficient sleep or that the sleep quality is impaired, similar to daytime sleepiness. Awakenings, what's happening in the middle of the night? Are they calling out? Are they having partial arousals? Sleepwalking, sleep terrors. Is there restless movement during sleep? What's the regularity of their schedule and their sleep duration? And then finally, is there snoring? So volume and pauses in breathing. I'm not going to go over each of these, but I wanted you to have this as a resource. So these are some measures that look at, some could be considered screeners that are shorter. So for example, the Brief Infant Sleep Questionnaire. Others have more items, but these are measures that you can use to assess sleep. These include the ones on this page include multiple domains. So insomnia, sleep disorder breathing, parasomnia. So they include both behavioral and then more medically based sleep disorders. And here are some additional measures that are more domain specific. So looking, for example, at sleep hygiene, pre-sleep arousal, daytime sleepiness. And then finally, intervention. This is a list of interventions that I've included that I think are very conducive to intervention in primary care. And in particular, I'm going to talk about 4 of them, but before I do that, just some quick data on the effectiveness of the brief behavioral treatments. So this was a American Academy of Sleep Medicine review of 52 studies, and then also the Kuhn and Elliott as a meta-analysis. They found that behavioral intervention produces reliable and durable changes. It helps most children. Most intervention studies have found good results, and the effect sizes are really quite large. So 0.8 to 2.31 standard deviations of improvement in sleep variables. So that's a lot of improvement for a brief intervention. And very importantly, no adverse secondary effects were identified. So no adverse effects on attachment, on infant mood, on parent-child bonding, on emotional functioning in children. And this is particularly pertinent because some of the Infant behavioral sleep interventions may require some temporarily prolonged periods of crying, and really there's not evidence to suggest that those are harmful in any way, and they've looked as long as 5 to 6 years after intervention. So let's review some of these interventions. So sleep training, there are a lot of approaches out there for sleep training. So the Ferber method, a basic cry it out approach, technically we refer to them as unmodified and modified extinction. A lot of options. I'm going to talk about one in particular that I like quite a bit. In general, the differences between the various sleep training options are, the decision is probably made based on family preference. There's not any evidence that one works better than another. So here are Mindell's sleep training steps for an infant who is having a hard time, or who's waking frequently during the night, yet is old enough to be able to sleep through the night without waking to feed, so around 6 months and older. So setting an appropriate bedtime. So for infants, that's somewhere in that 6:30 to 7:30 or 8 range. Having a consistent bedtime routine, so feeding earlier in the routine rather than later, so that the child doesn't fall asleep feeding. Putting the infant down drowsy but awake, and then having a parental plan for handling distress, so handling infant crying. She talks to parents about how it generally takes about a week. The average crying is 45 minutes. And to check as often as needed. So you can do a Ferber type approach where you wait a little bit longer each time, and you check at certain intervals based on the number of minutes. Mindell's recommendation is just to stay out of the room as long as you can. Of course, check for safety. Sometimes the checks can be comforting to the child if they become very aroused or upset, but to make the checks brief and boring. And then I think this piece is very, very important and not well known, that you can do sleep training at bedtime only. So you can do a cry it out approach where you put an infant down awake at bedtime only, and during subsequent night wakings in the middle of the night, you can actually rock them back to sleep, nurse them back to sleep, so that you avoid having them become overtired. And then in a lot of cases, the infants will then generalize. So they're learning the skill to fall asleep independently, and then they will start to apply that skill by themselves in the middle of the night. And for those infants who don't, you then can do sleep training approaches in the middle of the night. Again, sleep training approaches by parent choice, family decision. They need to be comfortable with it. But if they are interested and willing to do this type of intervention, then I think these are very helpful steps. The Bedtime Pass program is a great intervention for our preschool aged kids and sometimes school aged as well. And this is an intervention to address what we call curtain calls. So kids who are coming out multiple times after they're put to bed. I need to go to the bathroom. I need a snack. I need a hug. I want to watch TV. I forgot to tell you something. And this is a great, quick and easy intervention that parents can use. So essentially the child is given a bedtime pass. So a note card, a laminated piece of paper, and they can use the pass to get out of bed or to have permission to get out of bed. So let's sorry, there was an echo for a moment. Emma, are you all hearing echoes on your end?
No, you're just cutting in and out just a bit, just when you switch to this slide.
Okay. I'm hearing an echo on my side. I'm going to continue and try to ignore it.
Oh, some of our participants are also hearing an echo. I'm going to try muting myself, and we'll see if...
Okay. Let's see. I'm not hearing an echo anymore. Okay, great. I'm going to continue. So the bedtime pass is used, so when a child comes out, they can use their bedtime pass to, for example, get a hug or get a drink of water, some activities that are agreed upon. And if they do this, then they give the parent the pass. Once they're out of passes, they are denied requests. They're not allowed to come out again. And it's very simple, but it really works well. And I think it's important to have something physical that the children have that they can use. A fun variation is that if they don't use their passes, they can trade them in the next morning for some type of a reinforcer. So this has been evaluated and found to be effective, and it's recommended for ages 3 to 10. This is a strategy that's recommended for kids who are having nighttime fears, or who perhaps are sleeping in the parental bed, or a parent is sleeping with them and the parent wishes to transition away from that. Typically, if a parent wants to sleep with their child and it's working for the family, I don't try to dissuade them, because there's really not any evidence that it's harmful or that individuals sleep worse when they're making the choice to share a bed as a family. However, if a parent comes to me and says, I would like my child to transition out of my bed, then I think this is a great intervention. So essentially, the parent is providing the minimal amount of presence that the child needs to encourage the child to fall asleep quickly without a lot of resistance and stress and drama. Really, it's sort of like a systematic desensitization type protocol. So but instead of exposure, you're actually removing support. So you start the parent somewhere at one of these sample steps, and essentially you can start right here at the top, but if the child will tolerate, for example, the parent sitting in the hallway, then that is a better place to start. So you start again with giving the child the support they need to be successful, and then you gradually decrease the amount of parental involvement. And rather than doing it based on a certain number of days, you do it based on the child's response. So 3 nights where the child is falling asleep quickly without a lot of drama or crying or stress, then you move to the next step. And it can also be helpful to have some sort of a reinforcer every time you move to another step. And parents can add steps in the middle. They can skip over steps. Again, it's the basic principle is that you're giving the parent a plan to provide support for the child to fall asleep quickly, and then you're fading that support. And then finally, this is an intervention that's recommended for teenagers who are having trouble falling asleep or who are awake a lot in the middle of the night. So this is sleep restriction therapy, and it's a component of sort of the larger treatment package of cognitive behavioral therapy for insomnia. So the goal is to consolidate sleep. So you use either a sleep diary if you have it, or just a clinical interview where you get a sense of their sleep patterns to determine their typical patterns. And then you limit their time in bed that they're allowed to be in their bed to more closely reflect the amount of time that they're sleeping. So you set a specific bedtime and a specific wake time, and they cannot go to bed before their specific bedtime. Then at the return visit, you adjust the schedule. So if they're falling asleep quickly and staying asleep, then you move the bedtime earlier. You give them more time in bed. But if they're still showing insomnia symptoms, then you move the bedtime later. So you give them less time in bed, and you always keep the wake time the same. And I'll show you an example in a moment. You continue to adjust the schedule until they're achieving sufficient sleep without the insomnia, and then the individual continues on that schedule. And typically this is used in combination with sleep hygiene instructions. So for example, you calculate their average sleep time, how much time they're in bed, and their sleep efficiency, which is the average sleep time divided by time in bed. And then you set their schedule to limit time in bed to either their average sleep time or average sleep time plus 30 minutes. So for example, if you have a child who's going to bed at 9:30, but it takes them 2 hours to fall asleep and they're awake 30 minutes in the middle of the night, then really they're only sleeping 7 hours, but they're spending 9.5 hours in bed. So their sleep efficiency is 74%. And what happens then is a person will start to develop conditioned arousal. They stop associating bed with sleep, and bed can actually be associated with more arousal. So instead of feeling tired when they get into bed like a normal sleeper, they can feel anxious and more awake. So then in the case of this example, their sleep restriction schedule, so they're sleeping 7 hours, they want to wake at 7, you add 30 minutes to that, so you would say you cannot go to bed before 11:30. And then upon their return visit, if their sleep efficiency is good, but they're still sleepy, so they need more sleep, then you say, okay, you can have 15 to 30 minutes more time in bed. So you can now go to bed as early as 11. If, on the other hand, they come back and they're saying, you know, it's still taking me 2 hours to fall asleep, then you say, okay, your new bedtime is now 12 or 11:45. And this isn't, and there are a lot of really good resources about how to do sleep restriction therapy, but I just wanted to give you an introduction because I think that it's something that you can do in, you know, a quick 10 to 20 minute visit, and then quick follow-up as well. And then you continue to adjust. So just next steps in sort of understanding and improving sleep practices in primary care. So increase our understanding of current practices. So we know a lot about screening and guidance, but what are pediatricians doing right now, or what are primary care providers doing to treat sleep in primary care? And I don't think we have a good sense of that. Identify the best screening questions and processes. I hope I've convinced you that does your child have a sleep problem is not a great one. I want to test the behavioral sleep toolkit and then look at using informatics to change provider behaviors. I'd like to acknowledge my co-investigators, Taylor Saunders, who did the screenings with me, and also a lot of the work with the data, Faye Jones, the director of the clinic where we did the screeners, my mentor, Lisa Meltzer, Vince McCarthy, who is the director of the Sleep Center, the providers and trainees, and then participating children and families. My email is here if you have questions. Please feel free to email me. Also, if you have a site that might be interested in using screeners or testing some of these materials, please feel free to contact me as well. Thanks so much, and sorry we ran a little over, but I'm now ready for questions.
Great, thank you. Am I echoing now, or does it sound okay?
Sounds fine.
Okay, great. So our first question is, how are families referred to sleep consultants in your study that you had talked about?
That's a great question. You know what, I'm echoing again, but I'll try to ignore it. So essentially, we just walked into a room. So the sleep screenings that we did, there was no referral process. If there was a family that was waiting, we walked into the room and did the screening. So it was basically random, and it was anybody who was in the clinic.
Great. Our next question is, you addressed this a little bit, but if you have any additional information to share, what suggestions do you have for guidance when a child's sleep problems are mainly due to behavioral issues? For example, screaming for the parents, not wanting to go to bed, manipulation of routine.
So I think, you know, a lot of times I'll try to start with a good bedtime routine, in part because I think it sets the stage for good sleep. So using, for example, some picture charts for the routine, structuring the routine so that it starts with an activity the child likes, it ends with an activity the child likes. I think that sometimes adding support, so if a child is yelling and screaming for a parent, having the parent, and typically the parent was out of the room, having the parent sit in the room temporarily, if this is comforting to the child, and then fade it out. So sometimes even introducing supports. I think sometimes reward programs, although that, you know, I think we know that reward programs are most effective if the reward closely follows the behavior, and so getting a reward in the morning sometimes it's just too far away to really be motivating. But for some older kids, reward programs can be effective. Making sure the bedtime is correct. So sometimes if there's a later bedtime, temporarily the child is more tired, there's less drama, and then you move the bedtime earlier. So I think there's a long answer, but I think essentially you put supports in place to try to get a short, smooth bedtime process where the child can be successful, and then you slowly remove those supports. You remove the parent from the scene, you remove the reinforcers, you move the bedtime later.
Great, thank you. Next question is how to handle weekends when using sleep restriction.
Oh, yeah, great question. So the weekends are exactly the same. So you continue to maintain that set schedule on the weekends. Once somebody has reached sort of their final schedule and they're not showing insomnia symptoms anymore, at that point you can allow them to go to bed an hour later and sleep an hour later on the weekends. But during the sleep restriction process, weekends are the same as during the week, which is hard. It's very hard to comply with.
Okay, and then our next question, we have a hand raised, so I'm going to attempt to unmute Abby Miller. You're going to be able to ask directly. And you're unmuted.
I was curious to know about actigraphy studies in the pediatric population. Are those considered accurate and useful?
Yes, I think that actigraphy is very good at addressing some areas of sleep and not as good at others. So for those of you who don't know, actigraphy is, an actigraph is a wristband that's used to get an objective measure of sleep patterns. It measures movement, and based on that, you can get a pretty valid sense of things like how long is the child sleeping? Are they napping? How long does it take them to fall asleep, as long as you have a sleep diary that tells you when they went to bed. What actigraphy is not great with is telling you about night wakings. It's not sensitive enough to tell you if a child was awake. Now, if a child's awake for an hour, you're definitely going to see that on actigraphy. But if they're awake, say, for 5 or 10 minutes, it's just not a sensitive enough instrument to detect that. So it's not great for infant sleep problems, with night wakings. But in general, I think it's really very helpful. They're expensive though, and they're typically found only at sleep centers. Actigraphs, they're about $1,000 each.
Thank you. And we have time for one more question. So our last question that came in is, what are the biggest recommendations to help with sleep hygiene?
I think the weekday discrepancy is a big one. So less than an hour in between weekend and weekday. I think definitely avoiding electronic light within an hour of bed. So electronic light from TV, from phones and iPads can suppress and delay our natural melatonin. So talking to families about avoiding that close to bedtime. No caffeine after 4 p.m. Is a big one. A lot of the recommendations include don't exercise too close to bed, but I don't think we know exactly what constitutes too close to bed, and really there's some evidence that exercise helps people sleep. Having a consistent bedtime routine. So I would say those are probably the biggest.
Great. Well, thank you so much for your presentation and for answering all of our participants' questions. So as a reminder, our webinar was recorded and will be available on our YouTube channel if you'd like to share with any of your colleagues. And I hope that you all can join us for our webinar next month. Thank you.
Thank you, everyone.
Thank you, everyone.